collaboration between the brought to you by Health Confianza, collaboration between the UT Health San Antonio and the San Antonio Metropolitan Health District. Thank you very much for making the time to join us today. I hope you and your family are doing well. I would like to mention that we are recording this session today so we can share it later. But please note, anything listed in the chat will be seen in the recording. My name is Raquel Romero. I'm a physician by training, and I'm going to be the ECHO facilitator for the session today. We have a lot of information to cover, but before we begin, I would like to ask our UT ECHO IT person to provide some directions for us.
Hi, please stay muted unless you're speaking. You can use *6 on your phone if you call in, or the microphone icon on the bottom left of your screen if you join on the computer. You can also communicate with the chat feature. If you're having issues with your connection, you can always chat with me, UT ECHO IT. Thank you.
Thank you very much, Kale, for these instructions. Additionally, please remember, if you have some issues or some problems with the connection, you can always add that your comments in the chat, or you can send a private message to the UT ECHO IT. I would like to invite you and encourage you to add your comments, your perspectives, and your questions in the chat box. We will try to address them through the session today. You can also reach out to us after this session by email. And we promote interaction in our sessions, so we would love to see everyone's faces. So if you're able and you're comfortable, I would like to invite you to join us by video, particularly in the discussion part of the session. And please remember that no personal health information is allowed when discussing cases and scenarios. We'd like to mention that once you register for one session, you register for the complete series. I see that we have a large group today. Thank you so much for joining us again. And to help us with our attendance records, I would like to ask you if you please add in the chat box your name, your title, organization, the institution that you represent. Again, this is for our attendance records. Health Confianza is a county-wide collaboration to improve access and use the COVID-19 health information in the service in Bergen County. With that, and before we started, I would like to use this space to introduce our COVID-19 Health Literacy ECHO team. And I would like to start with Dr. Bergen.
Hi, and welcome everybody. I'm delighted to be emceeing this and helping facilitate this session. I am a professor of medicine at UT and also an infectious disease specialist and a proud member of the Health Confianza team. Welcome.
Thank you, Dr. Bergen, leader specialist. We have a Dr. Taylor is a panelist and didactic presenter today.
Thank you, Dr. Romero. My name is Barbara Taylor. I am a professor of infectious diseases at UT Health and a provider at University Health in the FACS Clinic, and I'm thrilled to be here with y'all.
Thank you very much. And then we have a case presenter, Dr. Sabat.
Hi, everyone. My name is Joel Sabat. I'm a professor of medicine also here, general internist, and precept in the medicine residence clinic, also director of the Breach Center.
Thank you very much for joining us our session today. We have Dr. Garcia, case presenter. I don't see Dr. Garcia. Maybe we can come back in a second, but we have panelists, Dr. Barnes.
Hi, I'm Dr. Niall Barnes. I'm a professor of pharmacy at the University of Incarnate Word and run a vaccine outreach project.
Thank you so much for joining our session today. And we have Miguel Cervantes.
Hi, everyone. My name is Miguel Cervantes. I'm with San Antonio Metro Health, and I'm happy to be here with you all. Thank you.
Thank you. Thank you very much. And thank you all for joining our session today. ECHO stands for Extension for Community Healthcare Outcomes, and this model is a learning opportunity and telementorship. And the goal of the model is to bring the knowledge when it's needed, where it's needed, to build community capacity for delivering the best practice care. One of the components is the didactics, and another one is the case-based discussion and dynamic conversation. So I encourage you to consider to present a case for our future sessions. And for those that already present a case, you can always present a follow-up for the cases presented. It is very important for us to hear from you. ECHO will share the instructions and for the case submission. Please check out our website to learn more about the ECHO model and the future sessions that we have. And these sessions are possible because of you. Please complete the surveys that you received here, and the link is going to be in the chat box. ECHO series offers the CME, and ethics continuing medical education. To obtain those studies, please follow up the instructions. So I would like to now give the space to Dr. Taylor for the didactics. Thank you so much. And once we're ready, we have the slides on the screen. Thank you so much, Dr. Taylor.
All right, can you all see the appropriate version of my slides? It's a victory. Thank you all so much. Okay, so I'm gonna attempt to give a brief update on COVID-19 vaccines, variants, and boosters. There's been a lot of activity, even just since the last time we did this update in Health Confianza in the last 4 months. A lot of things have changed. So bear with me, and I'm happy to take questions as we go along. This is the reminder. So my disclosures, so I am the site PI in San Antonio for what's called the COVID-19 Prevention Network, which is the NIH-funded clinical trials network that did the vaccine trials. So it's not through pharma, but we run pharma trials. Personally, here in San Antonio, we ran the Novavax trial. Shout out to the Novavax folks who are on the call, who were part of the clinical trials team. I also am the local PI for a phase 1 mRNA HIV vaccine trial for IAVI. Unrelated to anything I'm about to talk about, I also get some funding from Gilead Sciences through Southwestern for research on HIV and hepatitis B. So hopefully by the end of the next 15 minutes, you all will be familiar with current COVID-19 variants and a little bit of sort of likelihood of future variants. It is impossible to predict the future in COVID, as we have learned over and over again, but I will do my best to try to highlight some things. Think about current vaccine uptake and challenges with hesitancy, and then review the brand new late-breaking recommendations for COVID-19 vaccine boosters, which literally changed on the 2nd of September. So this is where we are as a globe, as a global community, as far as COVID in this week. So you can see that this is from the Johns Hopkins coronavirus dashboard. Many of us have been looking at this since January of 2020. And you can see that we still have quite a bit of COVID spread in North America. There's quite a bit in Europe. There's a lot right now in Japan, and less, but also less testing in other countries in Africa and some countries in South America, but there's still quite a bit of COVID in actually Brazil and Chile and Peru. Overall, our wave of the summer, which is the Omicron wave, which is sort of to the far right of the graph. I don't know, can you all see my arrow, my pointer when I'm pointing? Probably not.
Yes, we can.
Oh, good. All right, well, then I will use it purposefully. You can see that our Omicron wave had fewer weekly cases, many fewer, thank goodness, deaths. But we are also seeing a decline in vaccine administration. And this is very important because we are still seeing quite a bit of variation in COVID-19. So SARS-CoV-2 is the virus that causes COVID-19. It mutates pretty regularly, not as much as some other viruses like HIV, but it has continued to stymie us in terms of making new versions of itself. So this graph, or this data representation, really is the variation of COVID from back in the day, from early 2020 all the way up until June of 2022. The different colored dots represent different sequences of COVID-19. And when sequences differ significantly, and also they seem to spread slightly differently or have different clinical impacts, we call them variants. So you can see we started out with sort of the OG strain of SARS-CoV-2. This is sometimes called the Wuhan strain, but we're trying to sort of move away from that nomenclature. Then we had Delta. And really, for the last more than a year, we have been dealing with various variants of Omicron. Omicron it has been highly successful as a virus because it can cause reinfection for people who are already infected with Delta. It also, although renders our vaccines still effective in terms of reducing severe illness and death, it can cause infection in people who are vaccinated. And you see that Omicron itself is now split into multiple sublineages. And so right now, most of what we're dealing with is Omicron BA.5 and BA.4. I wish that we had better names for these things, but this is just where they're at. If you're a virus follower and wish to follow more variants of Omicron as they come out, this website, NextStrain, is actually a really good one with a lot of data aggregation. The data that I'm showing you here is global variation. I will say the reason I'm not also including a North American variants slide is because it looks almost identical. It's really our epidemic in the United States is paralleling the global epidemic as far as variants go right now. So we do shout out to UT Health, Metro Health, and the Texas State Department of Health have data on distribution of variants in Bexar County. These are updated as of August. And you can see that right now, what we're seeing is a lot of the Omicron version that's BA.5. And that really has replaced the earlier Omicron variants and has completely replaced the Delta variant. So we are in the era of vaccines versus variants. I've been using this analogy for a long time, but this is really, at some point DC Comics is gonna come for me, but this is really Godzilla versus King Kong as far as the tools that we have versus the pandemic that we are facing. But there is good news, even in the age of Omicron, where people who are vaccinated and boosted can still acquire SARS-CoV-2, the vaccines remain quite protective against severe illness and death. These are data from the CDC that go up to July of 2022, which show deaths in unvaccinated versus vaccinated. Very fortunately, overall mortality is down dramatically, but there is still significantly higher risk of dying from COVID-19 if you are not vaccinated. So I know a lot of us practice clinically. I still have patients who are unvaccinated. One of my unvaccinated patients got COVID this week. And those are sort of the scariest moments in clinical practice for me in terms of COVID, hoping that people who are unvaccinated still do okay. The other exciting data from CDC as well is the helpfulness of boosters. So these are folks who have had 2+ booster doses and are over age 50. And you can see that unfortunately deaths in people who are completely unvaccinated are high. Deaths in people who have primary series or series in 1 booster dose are significantly lower. And the most protected group are the folks who have had 2 booster doses. So that is and there are significant reductions in mortality for this. So this is encouraging, and we can tell our patients the boosters are helpful. Where are we as far as vaccine uptake? So I like to think of this globally because one thing that viruses teach us is that we are all connected, and there is no way, viruses do not care about borders. So there is no way that epidemics in other places in the world do not affect us here in the United States and here in San Antonio. So there are still significant disparities in access to vaccination, particularly in low and middle income countries. There's also still significant hesitancy and misinformation, and I'll talk a little bit about that in the next slides. There is also within the United States significant disparities from state to state and even city to city. We'll talk about that a little bit as well. So in 2021, the Kaiser Family Foundation started doing longitudinal surveys about attitudes towards vaccination in the United States. And I really would encourage y'all to check out their website because they have a wealth of data. And if you are thinking about communicating about vaccines with your patients, with family members, with community, it is a really helpful resource to sort of think about where people are and what likely information some people are getting about COVID vaccines. So these are updated as of July of 2022, the demographic predictors of unvaccinated status in adults in the United States. And so, unfortunately, we see that there are still dramatic disparities by income, by education, by age, by race and ethnicity, and by political affiliation. And so you can actually look at your clinic population, or you can look at the community you're serving and have an idea about whether or not people are likely to be unvaccinated in your community. These data are a little bit older. These come from last year. And if anybody can find the more updated data on this, I would appreciate it. But basically, some of these, unfortunately, a lot of this misinformation is still the misinformation that we hear in community now. They sort of did a question, which says, have you heard anyone say, or have you read anywhere that, and then followed by the statement, the government is exaggerating the deaths, pregnant women shouldn't get the vaccines, deaths are being hidden, the vaccines cause infertility, everybody should be getting ivermectin, sort of the list of various types of misinformation about the vaccine. And the most concerning part of this, I think, are the have heard and believed to be true factors. And so we're going to talk a little bit about communication, but it is really important to recognize that this misinformation is out there, is constantly put forward by groups, by all sorts of institutions. And so it is important to know that we are dealing with this on a regular basis. So how do you deal with this? So these are 6 communication skills promoted by Help Confianza. I just wanted to highlight them here. Setting the tone is probably the most important first step. I have patients and family members who are very much not interested in hearing from me about COVID vaccines. They are done. It's been 2.5 years, they're done hearing from me about the vaccines. So starting the conversation with, do you want to talk about it, is probably the most effective lack of waster of my time. And then the important follow-up is, if someone is really not interested in talking about it, letting them know that you're happy to talk about it at any point in the future. Keep the door open. I have been in places where I was really fatigued and I did not, and I always regret it. But I think keeping the door open for dialogue, using active listening, plain language, acknowledging different perspectives, bridging respectfully, and then using teachback are all really evidence-based ways to improve dialogue about this. There are also really helpful tools. This is one of my favorite, but there are many. The nutrition facts, many of us have heard, like, I don't like that stuff that's in the mRNA vaccine. So this is a great way to demonstrate to people my kids in public school had to learn how to read these nutrition labels. So everybody is forced to learn how to read them. Different people have different opinions about how useful they are, but this is something that we're familiar with, and we can use it to teach about mRNA
These
vaccines.
next 2 slides are revised. In the original live presentation, which at this point was a week ago, the recommendations were based on the CDC Immunization Guideline Pdf, which, as I discovered, is very easy to misinterpret and probably hasn't been updated as it should. So what I would say is, in the moment, and this is currently September 22nd of 2022, because these booster recommendations were revised just 2 weeks ago, there are parts of health information out there that have been updated, and there are parts that have not. So just beware. I actually created a table because I couldn't find anything that was sort of simple enough, I thought, to explain it well. But these are revised booster recommendations coming to you from the beginning of September of this year. And basically, the answer to should you get a booster is probably yes. So if you are under 12, there's not a booster recommendation for you yet. Check out for future changes, but there's not one currently. If you are 12 to 17, there is a bivalent booster. So these are boosters that contain the old version of the spike protein from the original vaccine and Omicron, the new Omicron that is circulating right now. And Pfizer is approved for the 12 to 17-year-old crowd. So they can only, at this point, get a Pfizer booster. If a 12 to 17-year-old has had their primary series of any of the shots, so Pfizer or Moderna or J&J or Novavax, you can get a Pfizer booster as long as it's 2 months after your last shot, and it should be the bivalent booster. That is including people who just got boosted. As long as you were boosted more than 2 months ago, you should still get a new bivalent booster. If you're 18 and over, the FDA has approved either the Pfizer or the Moderna bivalent boosters for you. And basically, if you've already gotten your primary series, no matter how many boosters you've gotten before, from none to 3, if you've had your last booster more than 2 months ago, you should get a bivalent booster. If you want individualized recommendations, if you're sitting in front of a family member or a patient or a client, you can go to this website and put in the information of an individual. You can do this for yourself as well. And the website will tell you if you should get a booster. So the simplest version of the recommendation is basically that anybody who's 12 or over who's received their first COVID vaccination series, so 1 shot for Johnson & Johnson, 2 for basically any of the other vaccines, and you're 2 months after your last shot, you should get a bivalent booster, regardless of your age, your immunosuppression status, any of those things. The CDC is doing this to really try to level everybody up with the new Omicron booster so that everybody gets the same amount of immunity as much as we can. Other important things to note, you can get this at the same time as your flu shot. You can also get it at the same time as your monkeypox shot if you qualify for a monkeypox shot. And you should please encourage people to get both. Our flu season this fall may be a not great one based on what we're seeing in Australia. Will these recommendations change? Of course. We'll have more data on bivalent boosters soon in all age groups, and COVID itself is constantly changing. We have now seen many, many different variants, even within Omicron, and so we will continue to adapt recommendations as new vaccines become available and new variants circulate.
There are also, it will not surprise you, health equity issues with boosters. These are data from February of 2022, so this has changed somewhat, but there are issues with age, issues with race, ethnicity, and issues with party ID as far as booster acceptance or getting a booster. And some of these things I will highlight are probably booster access issues. And then there is definitely booster hesitancy. And I think one of the most interesting things is the most common reason for booster hesitancy is they've got enough protection from COVID-19 vaccination or a prior infection. And I think if you look at the data, this is not a bad perception, right? We know that the primary series does protect you against severe disease or hospitalization. However, we now have data that the boosters protect you more. We also know very clearly the prior infection with COVID-19 does not protect you at all against Omicron infection. So practice takeaways include that the risk of COVID-19 in our community remains high. And I always point people to the San Antonio dashboard, which gives you graphics like the one that's in the top up here. Sorry, I don't even need to point, I can point with my thing, that shows you what the risk level in our community is. Omicron transmission of the BA4 and BA5 versions of Omicron is likely to continue through the fall, and boosters can make a difference with this. We should all expect misinformation and remember the 6 communication skills. I think really important is setting the tone and active listening and leaving the door open to conversations. And then finally, being honest and upfront about uncertainty. I think some of the missteps that I have made and others have made throughout COVID is trying to be clear and then being overly clear and not highlighting that there are things that we don't know. So I think it is really important to acknowledge when we don't have data about something. Thank you all so much for your attention, and I'm going to stop sharing.
Thank you. Dr. Bergen, you are muted. Thank you so much, Dr. Taylor.
Yes, that was really succinct and clear. And I have a question right out off the bat before we go to some in the chat. If somebody was never vaccinated at all, and now because we've used our wonderful 6 communication skills.
Let me check and unmute it. Barbara, can you hear me?
We need.
Yes, we hear you. But do you have a question or comment? But Dr. Bergen is.
I'll just, let me finish my question. If you've never been vaccinated at all and suddenly you decide, okay, I'm going to be vaccinated, should you go and get the new Omicron directed bivalent vaccine?
That is a great question, and it's definitely coming up. The answer is no. The guidance is you get the first series first. So we do not have data on primary vaccination with the bivalent old strain plus Omicron vaccines. We only have data on the first vaccine series being the old vaccines. And you can tell people that those still, even in the age of Omicron, will protect them against severe illness and death. And so they should go and get that series first. And then when they get boosted, they should get the bivalent booster. The charts from the CDC tell you exactly how long you have to wait after the second shot to get a booster. And in many cases, it's sooner than most people think. So I'd encourage you to look at that as well.
Thank you, Dr. Taylor. Dr. Bergen, I think you have a comment.
Thank you. I'm going to go to the first question that I saw in the chat from Shafkat Shah. For patients who have received mRNA vaccines, is it reasonable to offer Novavax now? And you're a Novavax expert, Dr. Taylor. Some report side effects of the mRNA vaccines or hope the immunity will make it last longer with Novavax. I guess that refers to some of the motivations that people are coming up with for why they'd seek a Novavax after having had mRNA series. What do you say?
All right, so I'm first acknowledging my clear bias for Novavax. Some people on this call were an integral part of this vaccine actually coming to market, and we're all very proud that it's finally available for folks. I think the Novavax vaccination is important in 2 contexts. One is if you have patients, and I certainly do, who have been hesitant about mRNA vaccines or viral vector vaccines, you can pitch a Novavax protein vaccine. Actually, a member of our study team just called up her primary care doctor because the MA there had been hesitant about mRNA vaccines and was like, I know you're on the Novavax team. Let me know when I can get it. And you can now get Novavax. Metro Health is offering it. It's offered at the Robert B. Greene as well. So you can get it. So if people just really don't like the idea of an mRNA vaccine, they can get a Novavax primary series. We do not have data for this context, which is people who got mRNA vaccine first and then getting a Novavax booster. Novavax boosters are not approved yet. There is a trial, we are part of that trial, but so we hope that that will be an option in the future. That being said, I know people who have done this. There is some thought that protein vaccine-based immunity would last potentially longer than the mRNA vaccine-based immunity. We haven't really seen data on that yet. So I would be cautious, as much as I am a proponent of protein-based vaccines, especially for people who are vaccine hesitant, and for folks who have issues with having negative 80-degree freezers on hand. I think that I would be hesitant to promise people that their vaccine is going to last longer because it's a protein-based vaccine, because we just don't have the data for that yet.
Excellent. Thank you so much. I see a question from Veronica. At the moment, I face that one of the main thoughts is to fight about is the general message that the pandemic is over. So general public link this to no need for vaccine. So I think what I'm understanding is because there seems to be a general perception that the pandemic is over, how do we speak with our public about the need for vaccination? And I would like to go for this question to panelist Miguel Cervantes, who kindly joins us from SA Metro Health in the vaccine division. Could you tell us your advice?
Sure, absolutely. Well, definitely, even though we are seeing less hospitalizations, it is still a risk for somebody to get COVID, and you do not know when you become infected whether or not you're going to be one of those individuals that is severely affected. So we are still recommending for everyone to go and get their vaccines, especially if we're also starting to see increases in cases of influenza. So we want to make sure that we're well protected against our respiratory conditions that we can be, to try and prevent some severe outbreaks of either influenza or COVID.
Thank you for that. I'd like to go to Dr. Barnes, who joins us representing the pharmacy profession from UIW, and who's greatly involved in immunizing. What messages and talking points would you add to what we got?
You know, Miguel nailed it, to be quite honest. You know, there are lots of folks that are convinced that it's over. Reminding everyone that it's more than just protecting yourself, it's protecting the people around you. We talk about cocooning patients with vaccinated people around them. And so reminding patients that maybe they're not at high risk for illness from this because they're nice and healthy and convinced of that, but they probably are around people who are high risk, and that they would decrease the transmission to them. I find that message works sometimes, but going back to Dr. Taylor's comments, you know, it's that open-mindedness and not shutting them down on their ideas, just sort of pointing that there are other good reasons to get that vaccine.
Thank you so much. At this point, since I'm seeing that it's 1:32, I'm going to recommend that we turn to our first case. And there were 2 cases that were submitted. And by the way, as our hub personnel are bringing up the first case, I believe, Carly, you have the ability to show us the first case. I want to mention to you all, we've tried to make this really streamlined and easy to submit cases to us. We're very excited that we're starting to see some uptake of this, but this is an all teach, all learn environment, as Dr. Romero always reminds us. And so all of us learn when people send us real live cases from San Antonio clinics and venues. So I would now like to call on Dr. Joel Sabat to share his case with us.
Thank you, Dr. Bergman and Dr. Taylor. That was a really clear presentation, Dr. Taylor, but it highlights I think this case highlights the challenge of keeping up with these new and ever-changing recommendations, right? So I was precepting in residence clinic earlier this week on Monday, and the resident presented a case to me. It was a patient, the patient was a 47-year-old male with prediabetes, obstructive sleep apnea, low back pain, and psoriasis, who presented for routine follow-up. So while I was staffing the patient with the resident, I asked the resident if he had discussed the new bivalent COVID booster vaccine with the patient. The resident said he hadn't discussed it because he thought the patient was too young, under 50, to be eligible for it. So the misconception then was lack of awareness of the age eligibility for the new bivalent booster, which, as Dr. Taylor discussed, you only have to be over the age of 12. Also related to that was how long has it been since his last shot. The new recommendation now is 2 months, not 4 or 5 months. And so it's really hard to keep up with this ever-changing information. I would say this is not a case of misinformation or disinformation. I suppose like he could have misinformed the patient if he said you're too young, but he didn't even get that far because he didn't think it was relevant. So again, I informed the resident that anyone over age 12 can get the new booster in as little as 2 months after their last booster, as opposed to age greater than 50 and greater than 4 months since the last booster. Should I read the questions, or should we stop there?
Well, I want to just follow up and clarify something. This particular patient was under 50, and it's also true that this particular patient is immunocompromised. 2 ways, at least, that we can tell, right? Maybe pre-diabetes, perhaps on immunosuppressive medication, maybe for psoriasis, or might need it. Dr. Taylor, how does the confluence of age and immunosuppression or lack thereof play in determining if someone needs a booster or not?
This is a great question because I feel like sometimes this is provider specific. For the reasons that you highlight, this is somebody who I would want to have a primary series and then 2 boosters because I would put them as moderately immunocompromised. If you go exactly by the rules, this person might not fit criteria, but considering the confluence of potential immunocompromising things, age, diabetes, psoriasis, potential medications, I think that this is a person who probably should have a primary series, which would be 2 shots for both Pfizer and Moderna, and then a booster, and then another booster.
And I have a follow-up question, actually, with this same guy. Imagine that, if you will, that perhaps this person already actually had gotten 2 boosters, because that could have happened, right? And now it has been more than 2 months since their second booster. They are under 50, but they are immunocompromised. Are we going to recommend that they go and get the Omicron bivalent booster?
So according to the current CDC guidance, no. That being said, I definitely know people who are going out and getting bivalent boosters in this context. Some of those people might be 80-year-old people who are directly related to me.
Any reason to believe that that would be harmful?
No, I don't think so.
Okay, I hope that was pretty clear. I'm checking over in the chat to see if there was anything else. Please, folks, feel free to put your questions in the chat anytime. And back to you, Dr. Savat. And Carly, could you please bring the case up again, the same one, because there were some additional questions on there.
Can I just add one thing? That the timing of, let's say we agreed that the patient should get a bivalent booster. There's disagreement about whether they should get it today or should they get it, sometime before Thanksgiving or sometime before Christmas, because we think it's probably going to wane in effectiveness, right? And I read a discussion about this recently from some of the leading experts in the country, and there was 50-50 disagreement on this. Like, yeah, I would get it today, or no, I think I might wait till October, November, right? Same with the flu shot for that matter, right? So that's another one of these situations where these are people who are trying to follow the guidelines and the evidence the best they can. They're getting their information from trustworthy sources that we consider trustworthy, and we still don't know what to do, right?
Commentary on that, Dr. Taylor?
I mean, I do think this is one of those things where it's important to acknowledge that there are not clear data, right? The best data we have, if you go to the ACIP slides for bivalent boosters, followed people for like 2 months, 3 months at the most. So and it looks like good antibodies to Omicron, so that's positive, but we don't know long-term sort of efficacy of the bivalent boosters. And I think it really depends. This is where sort of the collaborative decision-making is so important. I think some of the people who I care for really want it now. We certainly have, unfortunately, plenty of COVID still in San Antonio, even though our levels are going down. Others, I do think there will probably be more COVID in the late fall. So others want to wait. And I don't think there is a right or wrong decision about that, which is hard because people really want one or the other answer. And I don't think we've got one.
All right, thank you very much. Dr. Savat, do you want us to see if the audience will participate with us in talking about the challenges that they're experiencing with keeping up with the information?
Yeah, please.
Anybody from our community of learners want to share about this? And what do you find helpful? Where do you go for your information? Some of you obviously come to our ECHO series, which we appreciate. And if no one wants to share about that right now, I'm going to vote that we move on to our second case. So Carly, I'm going to ask you to bring up case 2, and I'm now going to call on our colleague, Dr. Cesar Garcia, who kindly submitted this case, a real-world case. Go ahead.
All right, so my patient is a 78-year-old female with history of breast cancer. She's on immunotherapy. She's on Ibrance. She went to the local pharmacy and received a Pfizer COVID bivalent booster, her and her son. And then she sent me a MyChart message letting me know that the pharmacy told her that the vaccine had not been refrigerated. And now she's concerned that maybe she needs to get reboosted. And then it didn't sound like the pharmacist gave them any information. So what I did, I asked her to ask the pharmacist what they recommended. So then as far as the relevant past medical history, the other concern I had is that she's immunosuppressed. She does have leukopenia from the Ibrance. The oncologist feels is related to that. As far as she's completely boosted, she's very compliant with everything, so that's why she's concerned. And she's never gotten COVID. Her son did, but she has not, which is interesting because the son got COVID last month and he already got boosted again, which it wasn't 60 days. So I was just curious about that too, because he's actually my patient too, and he had told me he got it, the infection, but they went ahead and they got it on their own and they got it already. So that's just a different clinical scenario. So then so as far as health literacy, she's high education level, very compliant. I don't have any concerns about low health literacy. She asks plenty of questions, so that whole like they don't ask questions, she asks plenty of questions. But she is the worry type, so right now this is going to cause a lot of anxiety because they want me as a provider to give them like the certainty that this is what needs to be done. And so, yeah, if you can give me feedback, that'd be great.
All right, thank you so much for that case. And this is one that caused a lot of head scratching. And actually, Dr. Garcia, I made a number of phone calls to try to sort out what might be learnable from the CDC and from Pfizer, the manufacturer. But before I share any of my experience on the telephone, I want to go to our panel. And I want to start with Dr. Barnes, if you would, please. So this patient received a booster, an Omicron bivalent booster, and then learns after the fact that there was some kind of temperature excursion. The vaccine wasn't stored properly overnight. We don't really know whether it was in a fridge and the fridge wasn't at the right temperature or whether it didn't get refrigerated. We're not told whether the vaccine had been drawn up into a syringe or whether it was in a punctured or an unpunctured vial. We don't really have any of those details. And this is probably not the only time that this has happened or will happen in the future. How does a clinician deal with this when their patient tells them, this is what the vaccinator people told me happened with my vaccine? What do I do now?
Well, first, I can't reach through the screen and strangle the pharmacist that gave the incomplete information. That's my first piece. But, you know, a couple of things. If we got a couple pieces of information, we'd have a little bit better piece. So if the pharmacist could provide whether it was drawn up in a syringe or not, that's probably not a good vaccine at that point and should be repeated, no matter what the circumstances is, because it was drawn from a vial and not stored properly. The second piece then is that pharmacist needs to get on the phone with the manufacturer and talk about the actual temperature excursions. As somebody who has 5 refrigerators with vaccines and a freezer as well, I've got temperature monitors on them. I have a temperature every 15 minutes during the day and night, recorded, wakes me up in the middle of the night if I have an excursion. If they have that good data and talk to the manufacturer can tell them if there have been any in-house studies that have shown that the vaccine is still viable with that type of excursion. So let's just say that it got left out for 4 hours. It was a 24-hour pharmacy. Somebody drew it up at 4 in the morning. The patient came in at 8, and it was at room temperature during that time frame. One of the manufacturers may tell them, we've actually looked at that and it's good, or we've looked at that and it's not. One thing I will say is only once in every time I've ever called a manufacturer about this have I gotten a manufacturer to tell me that dose was safe. Every other time they'll provide me with the information, and I need to make that decision myself or in conjunction with the provider that provided that vaccine. So we don't have good information, but I agree with Dr. Garcia that it needs to go back to that pharmacist that took care of the patient and not be punted over to Dr. Garcia when he has no data. I hope that was helpful.
Yes, thank you so much for that. And I'll share a little bit about what I learned today. I first called the CDC, and that's not hard to find. Anybody can find it. Poke around on the CDC's website for just a minute, and you'll find a clinician line that you can call with a vaccine question. And they were pretty prompt in responding to me. I didn't get put on hold forever, but they immediately told me that for this kind of question, it was ask the manufacturer, and they gave me the phone number to call Pfizer. So I called Pfizer, and I spoke to 4 different bureaus as one passed me along to the next, and there was a long wait in between each one. So all of this took over an hour. And at the end of that trail, I was informed that the manufacturer will never make management recommendations about a patient. They will happily take the information that you provide them about the temperature excursion and the duration of the temperature excursion or deviation of the storage protocol and let you know whether those scenarios are compatible or incompatible with the vaccine still being okay. And I was also told that it is the ACIP that advises, the Advisory Committee on Immunization Practices, that ultimately would give clinicians guidance about what to do in various scenarios. However, this is a pretty new bivalent booster, and that information is not posted by the CDC on behalf of ACIP. So I've put in the chat for you all the number that you can call for Pfizer drug safety in case this comes up, and it's an 800 number, and they're open Monday through Friday, starting at 8 o'clock in the morning. I would like to see if any of our other panelists, and I'm going to go now to Miguel Cervantes again, representing Metro Health. How would Metro Health handle a situation like this?
Thank you, Dr. Berggren. And like Dr. Barnes said, definitely call the manufacturer for these types of recommendations first, but to find some clinical guidance, in the interim clinical guidance from the CDC, they do have a number of different scenarios where, and errors, and that with some common recommendations or their interim recommendations on how to handle those types of situations. And so for any type of deviation in temperature, they do recommend that you follow up with the manufacturer, and if the manufacturer does not have any data to support that the vaccine was viable, their recommendation is to go ahead and re-administer the vaccine, and that there is no time frame to hold administering that second dose. So you can administer it as soon as that error was documented or known. And as far as Moderna, we talked about Pfizer having a call number, but Moderna also has a tool, an online tool where you can put in the deviation in temperatures and the different temperatures and the length of time, and they will have their recommendations on there. And one other item that I did want to mention, because Dr. Barnes did bring up a good point about having good temperature monitoring with his units at his facility, and that is one of the items that we've noted with particularly newer providers who hadn't administered vaccines before, is that they don't have the correct monitoring device. for the refrigerator to hold all that data where you can look back in time and look at that information to be able to provide it. So if you ever have any question about the type of device to get, you can, or to make sure that you have the correct type of device, you can always call us at Metro Health, and we can provide you with that guidance on whether or not that monitoring device is appropriate, and make some recommendations if needed on other devices to get if it isn't appropriate. And you can call our vaccine coordinator, Lina Agado, and I'll put her information in the chat. That way, if you have any questions about those devices, we can follow up with you and talk about your specifics.
Excellent. Thank you so much. And there's everybody look at the chat. Mia Vento has posted the Moderna temperature excursion tool. So we're appreciative of that. Dr. Garcia, before we move on, do you feel that we answered the questions that were brought up by your case, or did you have a follow-up for us?
Well, no, I just wanted to thank you, number one, Dr. Berger, for doing all that. I appreciate it, and it's super helpful. I'm going to follow up with the patient. I told her to keep me updated, but I'm going to, now with this information, I'm going to guide her more. And then, I just, regarding the son question, that he got the bivalent booster less than 60 days. I guess they didn't ask him any questions when he went to get the booster, but is there really good data on that for 60 days? Because it was 30 days, but I'm just wondering, and I know last time when we spoke, we were talking with Dr. Bowling, was saying maybe probably at 30 days, you start losing some of that protection from the previous infection. How is the data? How do they pick that 60 days as far as previous infection and then getting the booster by baby?
Dr. Taylor, do you want to field that one?
So the 2-month window is for getting the booster after you're getting your primary series, or getting a second booster after you've gotten your first series. If you look at, I was just looking at this because I also have this question comes up a lot, right? And so if you look at the CDC website, there's still this very hedgy language that says, when you get COVID, you might want to wait 90 days to get your vaccine. Some recommend. So to be honest, there are not unless I am missing the data, I don't think there are a lot of data on that. I think that we worry about getting vaccines close together, particularly in young men, because of the very rare risk of myocarditis for mRNA vaccines, and that was also seen for Novavax. Other than that, like, we have given, and I just, this is, in order to get people vaccinated, we have given vaccines for people who were hospitalized with COVID while they were still hospitalized, as long as they were done with their COVID. So I think it is okay for people to get vaccinated shortly after they get COVID. You don't want them showing up in the vaccine line while they're still infectious. So that's one thing, don't do that. But otherwise, you might want to wait a couple of months because they're probably protected for those couple of months. But if it's going to mean that they miss their shot, then I think early is better. And I don't really think that we have a lot of evidence for harm for getting the vaccine soon after a COVID infection.
Excellent. So
interested in what other people think about that.
Thank you. Earlier, we had a discussion with Dr. Sabat, who was wondering, how can we really find out when a patient had their shots? You're a primary care provider of any stripe, you're in clinic and the patient comes in, maybe they lost their vaccine card. That happens all the time, right? And neither you nor the patient is quite sure if a booster is due. What resources does the primary care clinician have? And I'm going to turn first to Miguel Cervantes, who can educate us about MTRAC2, and then I'm going to turn to Dr. Barnes, keeping an eye on the time.
So definitely, you can use our state immunization registry called MTRAC2. And typically, this registry is an opt-in system, meaning that you have to get the patient's consent to participate in the system. For COVID-19, though, there is an emergency use authorization, or there's an emergency response currently activated. So COVID-19 vaccines are required to be entered into the registry. So you will be able to go in there and look up the patient to get that information of what type of vaccine did they receive and when did they receive it. So if you currently do not have access to MTRAC2, if you're within Bexar County, you can call us at Metro Health, and I'll put the contact information again in the chat, and we can help you get an account. There are two types of accounts: view-only rights for those that do not need to enter administration data and just need to look up whether or not their patients received their vaccine. And then there's the full access, meaning that you are a vaccine administrator and are needing to enter or update vaccines. So you can enter vaccines administered or historical vaccines.
Miguel, thank you so much. And I don't mean to rush you, but I know that Dr. Barnes put some time and some effort into pulling up some resources, including something visual for us. And I believe Carly could pull up your slides, and maybe, I don't think we have time to go through all of them, Dr. Barnes, but we really appreciate that you brought this to us. And we know that there's a couple of those slides where there's something visual that we can look at that can help us quickly grasp how we get involved with MTRAC if we need to get information about a patient's vaccination history for COVID.
Great. So we'll skip to the next slide. The first couple of slides, and they'll post these for you, talk about where you can enroll, just like Miguel just told us, so we can sort of skip through those till we get to about slide 5. And there we go. So this is the typical page when you log into MTRAC. Many EHRs actually communicate 2 ways with MTRAC, so you might find this in your EHR as well. If you're using your MTRAC directly, there's a section on the left called Clients, Manage Client, or Enter New Client. Enter New Client, and if the client's already there, it'll find it, so you can sort of skip the Manage Client. If we go to the next slide, it'll show you the input. And for those of you worried about HIPAA, this is my data, and I can't break my own HIPAA rules. So here I am in it, and I've hidden my birthday and my address so that nobody tracks me down. But you would enter the data and hit the Find button, and we'll drop to the next slide. And on the next slide, you would find that it's got some details. And then near the bottom where I put this red line, you'll see an MTRAC ID. If you clicked on that MTRAC ID, you'll get to this page, which you can confirm address, mother's maiden name, and such to confirm you've got the right patient, and then click on immunizations, and it'll bring you to the next slide. And on this slide, this shows you in this middle section of the page, the current vaccines that MTRAC has registered for you. So if you look at my record here, you will see in 2021, I got an influenza vaccine. And in 2021, I got some SARS-CoV-2 vaccines as well. And you can see the dates and the types of vaccines that the patient got as you look through this. And then down at the bottom are recommendations from MTRAC2 of what the patient should have. I will tell you that the recommendations don't always work out well. And then if you were to press the Print Official Record button, you would get the next slide. And you would get a record that looks like this. You can sign it at the bottom and hand it to the patient so they have an alternative to their card. And this is also a way for you to look up and find out what they need from a vaccine perspective. It does not tell you, of course, their illness. It will also show monoclonal antibodies been given as well. I'll stop at this point because I know we're short on time.
Super. Thank you very, very much for bringing those resources to us. And thank you, Miguel, also for telling us how Metro Health can help with this. Dr. Savat, I hope we clarified a little bit about how providers could find the vaccination history. There's one quick question I want to toss in from Dr. Monica Verduzco Gutierrez. We're so glad you're here with us. And she was asking about flu vaccine and COVID vaccine boosters. Dr. Taylor, is that okay? Can we have them together?
It's all good. Get yourself vaccinated.
All right, and the first part of Dr. Gutierrez's question, I believe we had previously addressed with the timing after an infection or of a prior vaccine to get a booster. All right, well, we are at 1:59. This has been an excellent session. Lots of good information here today. I want to thank each of our panelists and toss it over to Dr. Romero.
Thank you. Thank you so much, Dr. Berger. Thank you so much, Dr. Taylor, for the didactics, Dr. Sabal, Dr. Garcia for the case presentation. And I just want to mention that these sessions are possible because of you, because of your interest, and your support and participation. I encourage you and invite you to submit cases. We would like to hear from the stories and the challenges that we are facing up in the community. And this is an environment that we all learn together. So please consider to submit a case or a follow-up cases. The information about the credits are in the chat. There are 2 steps. Please follow up those steps, and also please complete the post survey. The feedback survey is so important for us, and the code for the activity for today for the credits is 100-92230. Our next session is September the 30th. So thank you so much, and you have a wonderful day.